Hello everyone. So my name is Davina. I'm just going to share my screen. So welcome to the RCGP webinar for World Hearing Day 2024. So the theme for this year focuses on overcoming society's misperceptions and how we stigmatize mindsets about hearing loss. Now, hearing loss has often been referred to as an invisible disability. And as GPs, we play such a pivotal role in supporting patients to try and overcome these challenges by improving access to our GP services. Today, we are fortunate to have a panel of experts who will share the latest evidence on hearing and balance disorders and answer your questions and signpost you to updated resources. So a bit about myself. So I'm a GP with a specialist interest in ENT. I was invited to sit on the NIHR Deafness and Hearing Problems theme board as a primary care clinical advisor on the strategy team. And that was soon after completing my master's in hearing loss at UCL. I was then the national RCGP Deafness and Hearing Loss clinical champion, and I developed the Toolkit, which includes podcasts, e-learning modules, animation, and screencasts about deafness and hearing loss, which was on the QR code on the first slide that we shared. I'm also part of the priority setting partnership with the James Lind Alliance for coexisting dementia and hearing conditions. And my work outside ENT includes working with the UCL Primary Care and Population Department in Medical Education, and I'm a co-founder of Health Pioneers Charity, which helps young children in health promotion, especially in those in socioeconomic deprived areas. So what is the scale of problem? Statistics by NHS England revealed that missing NHS appointments due to the hearing loss could be as high as £15 million every year. And the UK economy loses 25 billion a year due to loss of productivity and unemployment due to hearing loss. There are so many health policy organisations out there, and they have stated in their action plans and their strategies that GP surgeries should really take steps to try and ensure that people with hearing loss can access GP surgeries. They can participate fully in their discussions about their care and meet the requirements of the Accessible Information Standard. So we have 12 million adults in the UK who are deaf, have hearing loss, or tinnitus. So that's roughly 10 million in England, 1 million in Scotland, 600,000 people in Wales, and 320,000 people in Northern Ireland. By 2035, we estimate there'll be around 14.2 million adults with hearing loss greater than 25 decibels across the UK. Now that's huge, and we call it that silent pandemic. So hearing loss can have a major impact on quality of life, on daily functioning. It can affect your communication. It can affect social interactions, resulting in loneliness and social isolation. Hearing loss has also had significant impacts on families and relationships. Research has even shown that hearing loss doubles the risk of developing depression and increases the risk of anxiety and other mental health issues, whilst many sufferers remain untreated or undiagnosed. So we need to try and identify people with hearing loss sooner and offer interventions earlier. And as GPs, we are best placed to do that. In light of the pandemic, deaf awareness amongst healthcare professionals was even more essential. So loads of healthcare professionals were using face masks to protect themselves from COVID, but that impeded communication because it would block the listener's view of the lips, and people sometimes are reliant on lip reading. So the QR code on this slide takes you to a BJGP Open article that we published in regards to communication tips. And I think actually one of the authors is also on this webinar. So shout out to Ted Leviton if he's here. So do have a look at that article. So what I'd like you all to do is watch this short clip about communication. It's quite a powerful clip.
So when I was really young, probably kindergarten or first grade, I have a much older brother, and we'd go out to recess, and there was this older guy, he might have been in like 5th or 6th grade, that always used to pick on us, and I didn't really know what to do about it, and I definitely looked up and completely trusted what my brother
Today we went to a high school and I pet I was posing for a picture with all of my girlfriends when all of a sudden one of them reached over.
Can you read my lips?
Can you read
My lips.
Can you read?
Can you read my lips? Can you read her lips?
My dad Clementine loves bread. She stole a loaf off the counter.
Can you read his
I
lips?
have two dogs. One boxer, she's 7.5, and one mixed breed who's 8.
I am deaf, but my word is a hearing one. I rely on the visual, not the auditory. The word lip reading implies reading, like reading a book
whose text is legible and clear.
But the human face isn't a book, and lip reading isn't reading. People mumble, people talk fast and laugh loudly, people have facial hair like porcupines, lips like sphincters, people cover their mouths, people have accents. But real conversations don't take place in a studio.
Growing up, I used to...
I'm putting together a puzzle without all the pieces. I lock in on your mouth. I try to grasp with one sense information intended for another. There have been times when I've questioned why I even tried to read. The way through this swamp, when I could just use sign language. Some deaf people choose to do just that. It's like a different world. A world filled with rich expression and culture. When people sound, they come alive. But I know I want both worlds. Communication is never a given.
Tuesday, I woke up, had a
And
rash.
she just pulled my dress down and
When I was little, my family
Everything was
got a
outside.
cat.
Like, why don't
Wednesday
you just
morning.
hit him in the
became
face?
a
That was like the last thing that I ever
guinea
would've done.
pig.
Last winter, I learned how to skate. I only cried twice.
But when the reading works, when I focus on one legible face and launch into a conversation, something clicks. Right then, I feel something extraordinary.
implies reading connection.
Connection.
Thank you. Now, that was a very powerful video to really put yourselves in the shoes of someone with hearing loss and the importance of communication. And in that article, we publish ways that healthcare professionals or even just the public can communicate with people with hearing loss. Okay, so now I know there's many GPs on this call, so here's some few practical tips for your GP surgery, and more links to websites and resources are available on the Hearing Loss Toolkit. So firstly, ensure you ask for and meet the communication needs of the patient where possible. RNID, so Royal National Institute of Deaf People, created a communication card. The card identifies the patient's communication needs, the communication support during the appointment, and how to be contacted, which can all be added to their records on whether it's System 1 or EMIS on your computer system. It meets the requirements of the NHS Accessible Information Standard, and both patients and GP surgeries can download the communication card. Another top tip, we have speech-to-text apps. They're very useful during consultations. They're widely available. They are free to download, and it basically converts the clinician's voice into written text, which can be read by the patient during the consultation if they struggle to hear you. I use that quite often. You can consider deaf awareness training for all primary care staff. It's not mandatory in the induction part of the NHS, but I think it's good practice to ensure, especially within GP surgeries where we see loads of people with hearing loss, to have deaf awareness training in your checklist. We collaborated with UCL Deafness, Cognition and Language Research Centre in the development of an online deaf awareness course, and it's been accredited by the RCGP. It's a 2-hour self-directed course, and it has videos of patients and doctors' real-life experiences. It talks about tips of how you can communicate, so that's useful to show your staff, and it's RCGP accredited. Consider using Relay UK for people with hearing loss, and you can also use video relay services such as Interpreter Now for British Sign Language users. A few more tips. A personal listener is a small personal amplifier which can be used for communicating with people who cannot hear at conversational levels. Now you can just order that into your surgery. So the patient wears headphones whilst the GP speaks into the microphone, which is the amplifier. The patient or the GP can adjust the volume dial on the amplifier to suit the patient's individual hearing loss. So this portable device is so useful and handy to purchase for your GP surgery. The telecoil system in GP surgeries can be beneficial for those where the hearing aids have the compatibility to switch to the T-loop system to help reduce the unwanted background noise in the GP waiting area, for example. World Hearing Day, as you all know, 3rd of March annually, and the World Health Organization developed the Hear Who app. So that's a free application on your mobile devices, allows you to check your hearing and intervene in early cases of hearing loss. A final tip for your consultations: hearing aids require reassessment and adjustment every few years, and GPs are well placed to remind patients of this. It could be done locally where the hearing aids were initially provided, whether it's high street stores or through the NHS audiology departments. So some support services for the deaf community, and more can be found on the toolkit. We're just touching upon a few things. Deaf Hope for domestic abuse help. Shout is a free 24/7 texting service in the UK for anyone in crisis, and it's not just for suicide, but any painful emotion for which you may need support with, and the NHS 111 BSL services too. So these are all useful tips to signpost to your patients. So the hearing loss toolkit. So we developed this a few years ago, actually during the pandemic time, and do check it out. It has podcasts, it has online screencasts, we have quality improvement suggestions, we have CPD teaching modules on there. Recently developed and launched the Essential Knowledge Update Tinnitus module after the release of the new NICE guidelines last year. The RCGP core curriculum for GP trainees has also been updated with references to hearing loss. So that's a very positive step forward. And we also developed a teaching PowerPoint that could be shown to all GP trainees nationally in all their VTS schemes. They just have to download it from the hearing loss toolkit, and that will help standardize some of the teaching around hearing loss. So new exciting parts of the toolkit we are developing and expanded on. So a lot of the information was around specifically deafness and hearing loss. And now the new parts are going to be around vertigo, dizziness, pediatric audiology, speak more about dementia and hearing loss, and tinnitus. So that'll be launched in the next couple of weeks, so do look out for it. So some take-home messages. So hearing loss is a common condition, especially in the older population. Communication skills are key. Early intervention is key, and hearing aids are the primary management option. So please do refer appropriately in a timely manner too. And managing hearing loss is key to a patient's physical, cognitive, and psychological well-being. And to end with, I just wanted to show you guys this short animation video that we all created with the RCGP during the development of the toolkit, and it was just prior to the pandemic to highlight ways to make your GP surgery more friendly. So I'll just end on this.
It took years for Michelle to ask for help. For a long time, she just kept turning the volume higher on her TV and asking people to repeat things. Although she has now been officially diagnosed with hearing loss, at times it affects her work and social life, making her depressed. Right now, she has a cough that's lasted a few weeks, and an internet search suggested she visit her GP. She made her appointment over the phone, which wasn't easy. At the GP's surgery, there's no visual display. Michelle's previously waited for a long time, having not heard her name. So she sits facing the receptionist and lip reads. The GP is not aware that Michelle has hearing difficulties and spends much of the consultation facing her screen. There is also a fan giving off background noise. The GP explains that the cough is viral and doesn't require antibiotics. But Michelle doesn't really hear her and is left wondering why she doesn't have a prescription. While most practices aren't like the one we've described, Michelle's experiences have been shared by many others. The best way to make your practice more hearing-friendly is to ask for and respond to patient feedback. To imagine that you are hearing impaired and think what it would be like to book and attend an appointment. In a more hearing-friendly world, she would have sought help for her hearing loss sooner. Her symptoms would have been recognised and diagnosed earlier, so that she could be referred to the kind of support that can make her work and social life easier. Notes in her records would have stated her preferred method of communication. There would have been a visual display screen so that she could watch as well as listen for her name, and a hearing loop that could transmit clear speech directly to compatible hearing aids or implants. The GP and staff within the practice would have undergone deaf awareness training. Seeing on-screen prompts stating hearing impairment, the doctor would have faced her directly, switched off her fan, and screened for the psychosocial impact of her hearing loss in terms of loneliness and depression. All of these things are also happening in many GP practices, but they aren't happening everywhere. In order to help, the Royal College of GPs has created a toolkit with useful advice and guidance, as well as a charter for you to sign up to, so that you can demonstrate your practice's commitment to being hearing friendly. We want to help reduce variation amongst practices, help them comply with the Accessible Information Standard and Equality Act, and for patients to have less stressful, more pleasant, and more useful interactions with their GP.
Okay, and here's some few resources for further reading. This presentation will be recorded and we'll share it afterwards so you can access it. And a QR code to link to the toolkit again. Thank you. Now I'm going to pass it on to our expert panelist, Crystal, and I'll let her introduce herself.
So good evening, everybody, and thanks for having me here today. My name's Crystal Rolfe. I'm the Director of Strategy at the national charity RNID. And it was fantastic to hear Davina's presentation then. Thank you, Davina, for all of that great information. RNID were briefly called Action on Hearing Loss. So some of the materials that you saw in Davina's presentation there, the Action on Hearing Loss on the record card, were from our charity when we tried a different name and we went back to our fantastic name of RNID, which was the Royal National Institute for the Deaf. So I'm going to talk today about hearing checks. Now, as Davina said, there's 12 million people in the UK who are deaf or have hearing loss. And that's quite surprising to many people. I've often spoken to GPs before, even who felt that there weren't many people in their practice who had hearing loss. And that's because there are millions of people who haven't done something about their hearing loss yet, which I'm going to talk about in a moment. Now, you might know the common impact that hearing loss has on people and becoming gradually socially isolated and having an impact on kind of depression, withdrawing from activities and that having a difficulty in work. But it also has an impact on dementia. And so in 2020, there was the Lancet Commission on dementia prevention, and it identified hearing loss as the largest potentially modifiable risk factor for dementia, and that hearing loss in midlife accounts for 8.2% of all dementia cases. There's lots of research taking place to understand if there's a causal link, and also to understand exactly how much of an impact there is. But we think that's really key. I think at the moment there's particularly a risk for those people who are at higher risk of dementia. The link is stronger. And NICE recommends hearing aids are the most cost-effective intervention for hearing loss as well. Why is all of that important? So there are millions of people in the UK who could benefit from hearing aids and don't have them. And it takes an average of 10 years to get help. And there's lots of kind of reasons people delay taking action, things such as stigma, people thinking hearing aids still look quite old-fashioned when in actual fact they don't, it not being somebody's priority and amongst their other health conditions, and also kind of systemic barriers or delays and difficulties in getting help. Because of this link with dementia, and because because, you know, of the kind of impact it can have, Alzheimer's Research UK have been working with us and calling for hearing checks to be available in the National Health Check. And we've been talking to the Office of Health Improvement and Disparities about that. That's our latest call. We did spend many years calling on the National Screening Committee to implement a national hearing screening programme. We're now talking about the NHS health check, and we think, you know, potentially that could be a hearing check in the dementia risk reduction section. And so we're really interested in taking those conversations forwards, and we'd be really interested in anybody that's got any kind of interest in talking to us about that as well. That's because much of our research has shown that people would be more likely to take a check if their doctor told them to, or if it was linked in with kind of another health initiative. In the meantime, while we don't have a national hearing check, we have been promoting our hearing check to the public. So we designed a hearing check using behaviour change methods. So my background is in audiology. I worked clinically in the NHS for years, and I taught on the BSc and MSc at UCL. But I also did a master's in health psychology at the Centre for Behaviour Change while I was there. And so we used behaviour change techniques, and we did lots of qualitative research, first of all, to understand the different phases people go through in identifying hearing loss, so kind of a pre-awareness phase, people being aware at the beginning, but it not being a problem, and then kind of becoming more aware that they needed to do something, and then finally wanting to act, and then it taking a long time for people to actually go to the GP from there. And that's where we've identified a couple of places where a quick online check could really help move people forwards a bit faster. There's lots of behaviour change models to create behaviour change, but we used one called EAST for this project. And so we looked at how we could make it easy to get people help. So kind of removing all the friction. So at every stage in our hearing check journey, we look to kind of refine it and make it as quick as easy as possible, making it attractive, making it social. So making it kind of a socially desirable thing to take hearing checks, just like you do like your eyes and check your eyes and your teeth. But also stopping telling everybody that it takes 10 years for most people to take action, and there are millions of people that didn't. We spent years doing that, and we realised that that wasn't helping at all. So you'll notice that whilst we say that now to professional audiences, we no longer say that to the public. And also making it timely, thinking about where we can reach people with a hearing check. So as I've said, we think that GPs are the best place that we can reach people with a hearing check. But in the meantime, we're looking at other places we can do that, such as catching them on social media when they're making a cup of tea and they've got a bit of time. We've got a reminder service on our hearing check, so people could, if they saw it in a noisy place, they could remind themselves to do it later. So on our hearing test, we focus on it being quick and easy and taking our check in 3 minutes. And we also focus on the fact that over 360,000 people have taken it so far. So that's that kind of social element of it, instead of saying nobody's doing anything about their hearing. You'll see here there's no note on dementia. What our evidence has shown is that although kind of some very targeted groups who are at higher risk of dementia are interested in knowing that, for a lot of people that just kind of put them off completely. And actually telling people you can take a quick, easy check, kind of people didn't really engage their brain. There was a kind of a low stakes approach, and they thought, okay, why not do something that takes a few minutes? And then once they've taken our check, we take them on a series of email journeys to make sure that they get a certificate, which they can then download and bring to their GP, and also then information about what to do next, regardless of whether they got a no result, there wasn't a problem, or yes, you need to take action. And this hearing check, the core part of the check was designed by Southampton Institute of Sound and Vibration Research and validated there by Professor Mark Lutman. So we think it's a really good check, but it is just a check. It's not supposed to be in place of a full diagnostic test. We did lots of work to improve the amount of people completing it, and 86% of people that start the check now finish it. We were absolutely bowled away by the fact that on our 12-week survey, 87% of people with potential hearing loss had taken some kind of action. So they'd either gone to the GP or they'd made an appointment, which was just unbelievable. And our hearing check was highly commended at the 3rd Sector Awards in the communication campaign category, which we were really absolutely thrilled about. We've had lots of coverage. So last year I got to be on the BBC Breakfast sofa on World Hearing Day a year ago. We've done lots of stuff around New Year, and we've had like several pieces in the news again this year. We've got links to our hearing check from all 4 UK NHS websites, and we've got 165 partners out there with QR codes, and I've got a QR code for GPs to use at the end of this presentation. That's all great, and that's all well and good, but as I said, our research has shown us that the best people that be telling people about checking the hearing are actually GPs. So we are trying to kind of get the word out there as best as possible while there isn't a national screening programme. But we think if GPs can be telling people, so for example, if you've got somebody in your surgery who seems to be struggling, or somebody that you think might be benefit, or just be telling everybody to be checking their hearing and with a kind of poster in your surgery, that is the way that's going to have most action, because people really trust their GPs. This is just to show you quickly, we've actually had like 9 creative phases, but we've tried lots of different things. So we've had a lot of detail going in here to try out different wording from behaviour change perspective. So every single sentence you see has been gone over with a fine-tooth comb, and then we've checked it out. And this pink one where it says, I did RNID's free hearing check on my phone in my kitchen, and it was easy to do and gave me a result in 3 minutes, is the one that seems to be working best. But we've really tried out different things. The illustrations, interestingly, are working better than the photos, which isn't what we usually find. People usually connect with other human beings. But we think that's something to do with the low stakes approach and people just thinking it's quick and easy and not having to kind of connect too much about the fact that this might be hearing loss and they might need to do something next. And then once we've got them, then they kind of go on the journey with us. And just a couple of quotes. So somebody's saying here, it's fantastic to be able to hear properly again. I used to miss a lot on radio and TV, and also sometimes got the feeling that people thought I was stupid because I couldn't hear what they were saying. And another one, I'm less stressed, sleeping better, enjoying work more, and more keen to socialise. And I generally feel I have more energy and want to be around people more. So as I said, we've done lots of kind of improvement. So we did have 46% of people completing the check at the beginning, and we've done lots of kind of very in-depth pieces of work looking at each part. And now we've got that up to 85–86% of people are finishing the check. And 40% of people are signing up for our email journeys afterwards, which we think is great. And we've got that reminder service. So if you did see our check when you were out and about in public, or for example, if you saw it when you were in a GP surgery and it was too noisy to do it there, you can press on the reminder service and it will remind you later on to do it. We've also created a guide for talking with your loved ones about hearing loss. Again, taking kind of low stakes approach. We think at the moment people are kind of very accusatory to each other, you know, you're all missing out on what I've said again. And actually that just results in a bit of friction and people refusing to do something. And so we've got that guide that we released at Christmas. We're also doing some work around health inequalities. So not only do we want to reach a huge number of people with our check, but we want to reach people who might be more likely to experience health inequalities, such as ethnic minority groups and people living in more deprived areas. We did some work with some groups from ethnic minority communities last summer, and we've kind of identified some areas where we could create some more inclusive communications. And we're looking at how we can pilot a community outreach approach at the moment in places of worship. And we're kind of encouraging further research in this area too. And this summer we plan on doing some work in more deprived areas. Again, kind of really open to any kind of feedback from anybody with any interest in health inequalities about how we can make our check better and how we can reach more of those groups. This is the important bit. This is a QR code specifically for GPs to share the check. So you can use that code if you want to promote the check in your own surgeries. You can also contact us. So this is my colleague's name, Lydia O'Connor. If you want us to create any particular materials for you, so if it'd be helpful to have a poster for you to download in your practice, we can create that for you. Equally, if you would like a specific QR code for your own practice, we can really easily make that. If you contact Lydia, she can create a QR code and then you can track how many people through your practice are actually taking the check. And you could target that to certain groups of people, but you could also it be something that you promote widely to everybody to use. And just before I go, I just want to also signpost over to another piece of work that we're doing that might be of interest to you. And that's our earwax removal campaign. And it kind of links to kind of hearing checks in that we know that we got contacted by huge amounts of our communities saying that they could no longer access wax removal services since the pandemic. And so there's our report there, blocked ears, blocked access to crisis of NHS wax removal in England. And so have a look at the report. And if anybody here wants to give us any information about how we can improve access in your area or through ICB, then please do get in touch. And I'll just flash up the QR code once more as I stop sharing my screen. And thank you for having me today. I think I'm handing over to Jean next.
I'm just going to speak for the first few minutes about my own situation. So I'm the person with hearing loss representing the world of all the people with all the different hearing losses today. I can't do that very well, so I'm just going to speak about my own and what's come of it, what I've done with it, and some opinions. In the beginning of this century, I had my first instance of sudden hearing loss. It's not always spoken about, but you GPs will know about it very well. So I had nausea and hissing ears, and I was dizzy, and I had no control over my life. I didn't know what I was going to be able to do when I woke up in the morning. Sometimes I could do nothing. I got in touch with my GP. I went into A&E, and everybody was a bit superficial with me, telling me that it would end quickly and it was a normal thing and it happened to lots of people. But it wasn't. It was idiopathic or idiosyncratic. One ear would hear one day, the other ear would hear another day, and then there would be a day when both ears didn't hear. I waited for a referral. It took a long time. By the time I got seen, it was a permanent hearing loss in one ear. And what happens, as you'll know, is that you see a lot of consultants who want to rule out anything sinister from their point of view, but they don't necessarily speak to what your concern is, which is, will I get my hearing back? Or what will my life be like? At the end, I had hearing loss in my left ear, and I asked for a hearing aid. That was my first instance. The second one was about 2010. I was staying with my daughter she was in university. she came in late at night. I was asleep and I lifted my right ear to hear her because the left wouldn't. And I didn't hear. And I screamed and didn't understand it. And we both said, well, it'll be better tomorrow. But it wasn't better tomorrow. And we didn't know, I know now, that what you need to do is get to A&E quick smart. You need to get to an A&E where they know to give you steroids, and it can be reversed. It isn't always reversed, but that opportunity was gone. Now my right ear was worse than my left. I had 2 hearing aids. In 2018, I was interviewing for the RNID magazine, the BBC broadcaster, Lewis Vaughan Jones, about his sudden hearing loss. But as we spoke, I couldn't tell him because it was his shot that I was losing my hearing as we were talking. I now think that it's because I did sit-ups at the gym that night before and that I damaged myself with that kind of a movement, an inner ear movement. We patients have theories. Whenever I asked anybody, they said, well, that would have been if it was BPPV, it would have been, it couldn't have been, but it's the only variable. And what it brought with it was something called diplocusis. Oh, let me tell you, I did get the steroids. I did get into A&E fast enough. Some of the hearing loss was reversed, but this diplocusis, which I wouldn't be surprised if you hadn't heard of, never went away. And what it is a difference in your pitch perception in your 2 ears. So one ear hears a higher pitch than the other. It means that music was destroyed for me because it all sounds like cacophony. And I play the piano, I sing. The only kind of music I can have is kind of drum and bass, you know, that works very well because it doesn't have pitch. So that's brought me into a younger community of dancing. The dancing at weddings doesn't work so well. Where does that leave me now in terms of my hearing and my life? Well, I'm one of those people, and you probably all know people like me, who changed their life for the better because of a disability. So I became involved in research, and I do work with Nottingham University. I do work with Leeds and with Aston and with Imperial College. And some of it has to do with hearing loss, but a lot of it has expanded beyond that. What do I do for hearing? Well, I don't know if you can see, I have hearing aids. They used to be red, and I wanted them to be red so people could see them, so they would know, and so that they would notice how to speak to me. Many people want them not to be visible, but I'm not ashamed. And I also can say, yes, okay, you think it goes with being older, but my hearing loss doesn't have to do with being older. It just happens that I'm older and have hearing loss. But anyway, they don't make them red anymore. For an occasion like this, I have a microphone, can you see, that it streams from the laptop to my ears. I have the streaming facility with my phone. I stream the TV and use subtitles, of course. Sometimes I go to a talk and I hand this device to the person speaking if I dare, or I might just hold it up, because even this distance from here to my mouth is a distance that air goes through and makes it harder to hear. Okay, I'm going to, if there's time, I have a few slides of 3 situations where that didn't go so well with primary care, and 3 that I'm imagining. So that's me with the GP being told that what I was going through was common, and it is common. But maybe if that GP had listened to all that was going on, maybe I would have had steroids then. Maybe my treatment would have been different. I had a feedback session with a nurse scheduled between 12 and 1 on Friday. You're allowed to phone, and the nurse will tell you how your blood test results. But I thought, oh, she's there, so I'll come into the surgery and I can see her instead, and it'll be easier to communicate. But as you see, the receptionist said, we don't do it that way. In fact, if you still want to use the opportunity, you can go outside and phone, but we're not going to let you see her. If you want a printout, we can give it to you at the end of her session. She was quite unpleasant. I don't think this always happens, and I think most GPs know how to handle people like me. I'm making a plea for you to train your complete staff and to monitor how they look at hearing loss. The person I saw said to me, all our GPs know how to talk to people with hearing loss, but she didn't. This isn't me. This is somebody I heard about. It was actually a young man who kept going to his GP saying he couldn't hear. And the GPs kept saying, but of course you can, because you're too young to have that kind of a hearing loss. He was sent away, and he ended up going privately to get hearing aids. So my point here is, you know a lot, but one size doesn't fit all, and please hear the exceptions. Now, some positive situations, and some imagined ones perhaps. So this is a GP who is holding, let's imagine, my notes. And on those notes, it says, Jean Strauss has hearing loss. This has never happened to me. I've never come in to somebody who knows that I have hearing loss, but that would be great. And the next thing is what a wonderful person with hearing loss, Sarah Chapman, wrote a blog about. How can I help you hear? That would be a GP or anybody saying, before we get started on this session, what can I do to make you comfortable with the fact that you can't hear? And the slide we're now looking at is about aftercare, because you might have a good consultation, but you don't know what's going to happen afterwards. How about if you said, how best would you like us to follow up with you? And many ideas have been brought today about ways of following up. Speech to text, or something with live transcription, or sign language, a phone consultation, or maybe I just have to see somebody. Those choices would make patients feel a lot better. I know it's challenging when a patient comes in finally or for the first time and says, I think I'm not hearing that well, but they're reluctant, or they've been forced to come in and they feel ambivalent. Wouldn't it be great if you said, look, I've got this screener here, not a room, but just something, let me test you now. Or use the RNID, something instant, so that there's an answer, so that you can move on from that. And also, wouldn't it be great if that patient who was worried was told it might be wax? I have a device here, let's see, let's get it out. and then we know how you're hearing. But finally, if that person comes in with sudden hearing loss, back to where I started, please refer them for urgent assessment. Get them out of your office into ENT. Pay for an ambulance. Give them money to get there, because there's only a limited time that it works. So time is of the essence. And I've taken too much of yours. Thank you very much.
Thank you, Jean. That was really moving and really, really great to hear. I'm just going to share my screen. So thank you so much for inviting me to come and talk again today, Davina. My name is Jack Stancelos. I'm an audiologist, and I supported with the initial development of the toolkit. So I'm going to talk today just about hearing health and how that supports healthy living. So just an overview of what I'll touch on. I appreciate we're short on time, so I'll do a slightly lighter touch approach. But just touching on hearing across the life course, we'll be focusing on hearing loss in adults, just highlighting the importance of hearing in childhood and middle life. The impact of unsupported hearing loss. I'll talk about an initiative that can support behaviour change. And then we'll touch on some groups that are at higher risk of hearing loss and potentially face greater challenges to accessing care. So, as I mentioned, we'll be talking about hearing loss across the life course. And I thought it was important to highlight how healthy hearing and hearing loss prevention is important across the life course. As you can see here depicted on the WHO's World Report of Hearing from 2021. We need to think about both causative and preventative factors and how they interplay to determine, the occurrence of hearing loss at different stages of life and how hearing loss might progress. And I think we need to sort of think about how we promote preventative choices by managing or avoiding modifiable causative effects like smoking, and that could support early intervention at any stage of life as we move forward. So we heard earlier from Crystal and Davina about the stigma associated to hearing loss and seeking help for hearing issues. So I really like the WHO's call to action about changing mindsets, but I think these things to what we've been speaking about today. So hearing loss is the largest contributor to is the third largest contributor to years lived with disability, behind lower back pain and migraine, as indicated by the global burden of disease. However, in over 70s, it is the largest contributor to years lived with disability in sort of Western Europe. Hearing loss impacts our access to spoken communication, environmental cues that can have a significant impact on our daily activities, such as walking and using the telephone. It can impact our mental health and limit our social network and result in risks such as falls and impact our physical health issues as well. So hearing loss is also associated with a range of negative health factors such as cognitive decline and other long-term health conditions like cardiovascular disease, hypertension, stroke, and diabetes. But hearing aids can improve our quality of life and may reduce our hearing handicap and promote better physical health. And therefore, by promoting hearing health as part of healthy living, we can kind of normalize that process for seeking help for hearing loss and checking one's hearing. So I just wanted to talk about the project, the Hearing Birdsong project here that we can see. Just hope that you can see here. So this project was a truly co-produced project that I had the privilege of being part of. It was co-produced between patients, healthcare professionals like audiologists, designers, architects, and engineers. And Jean was also a member of this group. And it was a different approach to awareness and behavior change in a sort of non-clinical way. Being able to hear birdsong is really valuable to a lot of people. And this project was motivated by Angela's story, again, who you can see in the photo here, about when her regular walk through the woods, during her regular walks through the woods, birdsong gradually faded until she could no longer hear it. And this drove Angela to sort of get help for her hearing and get her hearing checked. So sort of thinking about how that could support the process was really interesting. The installation consisted of a series of bird boxes with speakers that played different birdsong. And they were sort of installed in different places like community setting centres and places like the Kingsland Shopping Centre, for example, to try and be in the community and support people to think differently about hearing loss and so on, so they might seek help sooner. And you can find out a bit more about the Hearing Birdsong project on their website and the Twitter page. Here, I just wanted to talk about these groups where there are potentially higher prevalences of hearing loss, but individuals may face greater challenges when accessing healthcare. And it may be misconceived that individuals in these groups will not hear hearing aids, not wear hearing aids, or will benefit from hearing intervention. So just trying to change those mindsets and those conceptions as part of that sort of World Health Organization call to action. So firstly, I think really important for you and your patients to know the signs and symptoms of hearing loss, which might be people asking for the TV to be turned up louder, or suggesting that others are mumbling. I think really important to remember that if people can hold a conversation in a quiet room, doesn't necessarily mean that they don't need to be referred for assessment. I think just to touch here, in addition, people with learning disabilities or cognitive impairment may also exhibit changes in their behaviour, which might be withdrawal, agitation, and they may also change the way that they react to sound. For example, if they previously turned their head and they didn't in this case, that might be a sign that they have hearing loss. So you may be surprised to hear that approximately 40% of adults with a learning disability have a hearing loss. People with a hearing loss are also at greater risk of other ear health issues such as impacted WAC. But they may have difficulties expressing the changes in their hearing, or the signs of the sort of changes in behaviour may be put down to their learning disability and might not be picked up. So it's really essential that we support people to access hearing care, especially if they have a learning disability, even when verbal communication is not their sort of preferred mode of communication. So it can still support that process. People with a learning disability 14 and over are eligible for an annual health check, and this is really important. That hearing it forms part of that. Some work done by Lindsay McShay in Sunderland highlighted that including a more formal form of assessment, a sort of objective hearing test, actually supported greater access and referrals into audiology assessment. They found that only 18% of those individuals had been highlighted as having concerns. So potentially those self-reported or whisper tests that you might be conducting not picking up the issues as they should do. So just touching on here, similar to what Crystal mentioned earlier about the potential, about the association between hearing loss and dementia is really important. So hearing loss and dementia are strongly associated, and hearing loss may not be detected in people with dementia, as there are sort of overlapping symptoms and sort of other health conditions take priority. So I think it's really important that we try to support earlier intervention that are suspected of having dementia or may have dementia, and we support them to access audiology services sooner to enable them to adjust and adapt the hearing intervention. I think it's really important, as well as part of both of these conditions, both learning disabilities and dementia, to highlight the individual needs that they have, so the audiology services can tailor their approach to provide a more personalised care. These are just some checklists that were developed with the London Dementia Network to sort of a more formal approach of asking about hearing loss and including family members as part of a dementia assessment. And the questions are based off the sort of common signs and symptoms of hearing loss, and might support that approach to considering a referral to as well. So a large proportion of care home residents have hearing loss, and they often have other conditions in addition to hearing loss, like dementia. So residents, when they're moving, if they haven't had their hearing loss once they've moved into a long-term care facility, they may be missed because there's a focus on those other conditions, because the sort of care staff might not be aware of the importance of hearing and sensory health issues in comparison to other health issues. So really important to consider all of your patients or all of the residents within a long-term care facility for hearing assessment, due to that sort of the sort of factors that might influence them having a higher prevalence of hearing loss. And again, really important to highlight the supportive needs as part of your referral to audiometry service. Get this bit, but just in conclusion, I think we really need to consider healthy hearing as part of healthy living, promote prevention and action. Earlier intervention is essential. We need to normalise hearing check across the life course and support access, and actively support groups that are at risk of higher prevalence of hearing, such as people with a learning disability, dementia, or those that reside in care homes. And again, due to wax being more prevalent in these groups, people and other people will need to consider that as part of the assessment process. So thank you. I'll stop there.
Thank you, Jack. And thank you to all the panelists. I know you've all sent in Q&As, and we've tried to answer best as we can. Okay, well, thank you, and enjoy your evening, everyone. The recording will be sent out by RCGP to everyone, and look out for the hearing loss toolkit resources and the new dizziness, balance, dementia, hearing loss and tinnitus things that are going to be coming out on the toolkit. Thank you. Have a lovely evening. Bye.